Good morning, everyone, and thank you very much for attending. I think we'll have some folks signing in as we go along. This is Gary Greenswag. I am the physician executive for the Physician Enterprise and very happy to welcome you this morning and to say, I wouldn't say be the first to say, but to say happy holidays for the next few weeks and Happy New Year and all of those good things. And we hope people have good times with family, friend, and significant others. And I would remind people that a few months back, we had a strategic summit in Chicago for the Physician Enterprise. And at that, there was an awards and recognition program for the Vision Awards, Physician Enterprise Vision Awards for CommonSpirit Health in multiple categories, one of which were academic papers. And we recognized several authors, paper authors, and teams over several domains, including both attendings and residents and fellows. And as with last year, we ask people who submitted papers to come to our grand rounds and do just a brief summary update of their paper, what it was about, and kind of the essential takeaways. And so we have three authors this morning, all award winners in their categories. And I'm going to first introduce our speakers, and then we will proceed with papers. So we found last year this was an engaging and a great way to not just recognize the author, but to be sure that folks who are out in the communities get a chance to think through these papers. So first, I'm going to introduce Dr. Una Lee, who, as I recall, had two papers that were recognized. She is the section head of the section of urology and renal transplantation in Seattle, Washington, and the urology physician lead of Virginia Mason Franciscan Health, which is a member of CommonSpirit Health. She is subspecialty board certified in urogynecology and pelvic reconstructive surgery. She serves as associate program director for the urogynecology fellowship at Virginia Mason. Her undergraduate and medical degrees are from Stanford University. She completed her urology residency at the Cleveland Clinic and completed her fellowship in female pelvic medicine and reconstructive surgery at UCLA. Dr. Lee's clinical practice is focused on evaluation and management of female pelvic floor disorders and with a research focus on the delivery of patient-centered care, which we'll hear about today. Next, Dr. Rachel Bond has been with us before, is a board-certified attending cardiologist in Arizona who has devoted her career to the treatment of heart disease through early detection, education, and prevention. Her clinical interests include heart health prevention and maternal health. Dr. Bond is a fellow in the American College of Cardiology, who's most recently has been appointed as a member of the National Diversity and Inclusion Committee, a member of the American Society of Preventive Cardiology, where she sits on the editorial board, and a board member and co-chair of the Cardiovascular Disease in Women and Children's Committee at the Association of Black Cardiologists, where she is leading efforts surrounding the Black maternal health crisis and the American Heart Association. And the American Heart Association, where she is a national spokesperson for Go Red for Women campaign and sits on the board of directors. Welcome. Dr. Bond received the coveted Nanette Wenger Award for her work and advocacy in women's health, along with being named one of the most significant influential women in Arizona in 2022. Welcome again. And last but not least, Dr. Ann Kennard is the Associate Program Director of the OBGYN Residency Program and Chief of Lifestyle and Integrative Medicine at the Marion Regional Medical Center in Santa Maria, California. She is triple boarded in obstetrics and gynecology, lifestyle medicine, and integrative medicine. She is the chair for wellness and at the American College of Obstetrics and Gynecology. She teaches nationally and is published in topics surrounding physician wellness and women's integrative medicine. So welcome to all of you, and thank you for being here. So I believe we're going to start with Dr. Lee.
Great. Good morning. Thanks everyone for being here. So my presentation today is going to be on creating an extraordinary experience for women undergoing cystoscopy, a patient-centered approach to process improvement. Here are my disclosures. And here are the learning objectives. We're going to review the concepts of the Virginia Mason production system, discuss the goals and purpose of the process improvement project for improving the cystoscopy experience for women in urology, and review some principles of patient-centered healthcare. This is a visual of the Virginia Mason production system, which exemplifies some of the values and the strategies. And as you'll note, the patient is at the very top of the pyramid. It just sort of represents what a priority the patient is in this. And just as a review, actually, I'm going to go to the next one here. The Virginia Mason production system, this is another visual, is a management system that is based on the Toyota production system. It took manufacturing principles of efficiency, safety, quality, and it has applied them to healthcare so that we can streamline processes and make the experience better for the patient and all healthcare workers. So some of the key features of the Virginia Mason production system is, as circled here, patient as partners with patient-centered approach, and also lean thinking. So value stream mapping, Kaizen events. Kaizen is the continuous improvement event. Called 5S methodology, which is improving by organizing workplaces, eliminating waste, standardization, empowering staff, and having a lot of visual tools, and with certainly a focus on safety and quality. So as part of my training in this methodology, I developed and hosted a Kaizen event. And as I said, Kaizen means continuous improvement. And I chose this topic because actually I was inspired by a negative online review. A patient wrote about a negative experience they had during cystoscopy, and I was personally very saddened and mortified. But at the same time, I looked at that and I said, how could I looked at it as feedback, and I wanted to improve the process that women go through with cystoscopy so that would never happen again. So we did a deep dive and we developed this event where we examined the cystoscopy process for women to improve it based on patient input. And as a review, cystoscopy is a common urologic procedure. We take a little camera and a scope into the bladder to examine the inner lining. This can be diagnostic and or evaluate for issues. And it's interesting because we've learned that women perceive it as invasive, personal, and fear-inducing, and they want to be treated as individuals and not just another procedure. So I'm going to go through our process and our learning. And I just want to remind people that, yes, we're talking about cystoscopy here in this specific event, but actually the learnings are very universal to any healthcare procedure, any healthcare process, and really how to put the patient first and how to rethink our perspective. So we start with the current state. This is the left side of the slide where we consider this procedure minimally invasive. We may do many, many of these a day, and we think it's sort of a quick procedure, not a big deal. But even if you walk in the shoes of the patient and you look at their viewpoint, right? I'm not looking at the procedure or the equipment. They're laying on a bed and they might be cold. They might be scared. They're looking at the ceiling. They may see this open door. They may feel very vulnerable. And so for them, it's very invasive. There's something going, inside of them. While we may do many a day in healthcare, for them, it might be the one they have in their whole life. And so they may not know what to expect. They may have fear of the unknown. And so I think this is a good reminder of the different viewpoints. So we start by collecting a lot of data. And this is through Virginia Mason production system tools and also principles of experience-based design. So we collected emotion word lists, customer debrief forms, patient surveys. We asked them about their perception of wait times, which is actually interesting because if they felt well taken care of, they perceived the wait time to be less. Whereas if they kind of felt like they didn't know what's going on, they perceived the wait time to be longer. We did in-person virtual patient spotlights, these interviews, and heard their stories. And then we did a lot of simulation where we practiced what would it be like this way or that way, and we were doing the, what it felt like. So then based on patient feedback, we implemented a lot of improvements in a PDSA form, Plan, Do, See, Act, and some of these have been long lasting. But one of the main ones was we trained and empowered staff to demonstrate omotenase. Omotenase is a Japanese concept where you're anticipating and being thoughtful of someone's needs before they even know it. So a good example of this is at a Japanese restaurant, you get the warm towel and you didn't even know you need it, but it was so lovely. And so we're, again, having our staff treat the patient and envelop them in these comfort measures, meeting their emotional needs, assessing their emotional needs and then meeting them, assessing their knowledge needs and their physical needs. So educating them on the process, answering their questions. Small gestures can make a big difference. And don't assume they know what a cystoscopy is. Don't just tell them to relax, show them how to relax, as the procedure goes on. So this represents a paradigm shift in healthcare called patient-centered care. Current state, as we know, it can be very confusing for patients to understand relevant healthcare information. Processes traditionally are designed around the healthcare provider or the healthcare staff. Patients may be passive. We assume we know what they need, and it can lead to patient frustration. So what we're striving for is that they would receive and understand high-quality information to make well-informed healthcare choices, that the processes would be designed for and with patients so that they feel empowered. The care is individualized, and we can lead to satisfying, even remarkable and extraordinary patient experiences. So this is a diagram that represents the principles of patient-centered care. Mission and values align with patient goals. Care is collaborative, coordinated, accessible. Physical comfort and emotional well-being are top priorities. The families and the patient's viewpoints are respected and incorporated. And it's a welcoming setting with full transparency and delivery of information. This was the word cloud generated from the emotion word list responses by the women undergoing the cystoscopy. And as you can see, it's a broad range. This was a bus that went by the day we did this Kaizen event, and I just thought it so encapsulated what if every patient felt like the only patient? That's what we want our patients to feel, and we can do that. And this is one of my favorite quotes by Maya Angelou, and it reminds us that patients divine value in healthcare. Every step should add value to the patient. I've learned that patients will forget what you say, patients will forget, actually it says people will forget what you say, people will forget what you did, but people will never forget how you made them feel. So we should strive to make every process in healthcare one where patients feel valued, cared for, acknowledged, comfortable, that they have their, they have educational needs met and their emotional needs met. So lots of learning in this process, and I really appreciate people listening and being interested in this. It's a small project, but I think it has big implications.
Thank you, Dr. Lee, while I pull up my slides. So as mentioned, a lot of the work that I have done nationally is with the American Heart Association, and I was extraordinarily fortunate to have the opportunity to be part of a scientific statement that was published back in 2023. The title of the statement is Cardiovascular Disease Risk Factors in Women. The goal of this statement was really to express the impact of race and ethnicity as it pertains to the overall cardiovascular structure. So I will go through that very briefly today. I have no relevant financial disclosures. The goal for the next 10 minutes is to really understand the landscape of how cardiac disease impacts us as a whole in the United States, but more importantly, as it pertains to sex, gender, race, and ethnicity. Understand the limitations of traditional risk factors and the power of non-traditional risk factors. And last and most importantly is to really delve deeper into the scientific statement, which was a literature review that gave us the opportunity to really delve into where the current evidence on racial and ethnic differences lie as it pertains to women. And I I do want to emphasize that all race and ethnic groups were looked at. For my specific focus, it was mainly on addressing Black women who do face the greatest risks of premature heart disease, as you'll learn. I do want to acknowledge that all of our authors, for the most part, were also females in the field of cardiovascular disease. The only one who was not was the then president of the American Heart Association, Dr. Roger Blumenthal, who is a wonderful he for she. But why this is important, as you'll hear in my lecture, is that diversity in all forms of medicine will help to improve these staggering statistics. And we know that there is lots of data to support, particularly in cardiology, when there is a patient-provider concordance, it often leads to good patient outcomes. So as a background, heart disease is a leading cause of death in the United States, and this is despite it being preventable 80% of the time. Oftentimes, we see these disparities among race and ethnic groups, and as I already alluded to, Black women face the highest prevalence and mortality rates. They're actually dying at younger and younger ages. And when you look at Black women globally, one of the more common traditional risk factors that often is contributing to this is hypertension. Globally, they do have about 55.3% risk of cardiovascular predominance of hypertension. We also know that they have elevated lipoprotein(a) levels. So lipoprotein(a), for those that are not familiar with it, is a genetically predetermined risk factor that oftentimes can cause the vessels to be slightly more sticky. And as a result of that, it can predispose you to premature cardiac disease. So it's not just pro-atherosclerotic, it also could be pro-thrombotic. So as a result, they could have higher incidences of ischemic strokes as well. They are also disproportionately affected by other traditional risk factors, obesity, diabetes, or smoking-related diseases as well. So it comes as no surprise that Black women are really at the greatest threat when you think about it nationally, when we separate this by race, ethnicity, sex, and gender. Greater than 1 in every 2 Black women have heart disease, and there's an even higher chance of mortality, especially at a younger age. So when we think about the age group, it's typically anywhere between 35 to 54 years of age. So when it comes to Black women, nearly 60% above the age of 20 have some form of cardiac disease. Heart disease accounts for 22.9% of deaths among Black women. And if you just think about it in like a theoretical perspective, if you have somebody who's at the highest risk and that risk is occurring at a much younger age, we're going to have limitations in some of these traditional risk factors that may take time to either develop or may take time to actually cause problems. As a result of that, it makes it slightly challenging to comprehensively estimate a person's true risk factor. And should we be looking more at these non-traditional risk factors, the ones that do unfortunately disproportionately affect communities based on their race and ethnicity? Common ones include pregnancy-related complications, preeclampsia, gestational diabetes, or premature labor. All of these are more prevalent in Black women, and they are risk factors that could impact a patient's life up to 20 years after the actual inciting event. We also know that psychosocial stressors, such as discrimination, lack of social support, lead to elevated cardiac risks. Environmental exposures like lead and air pollution, which disproportionately affect Black women. And mental health conditions like depression are also associated with higher cardiovascular disease incidences. And many of those fall under the category of social determinants of health. Many of the greatest drivers of health are often beyond the scope of healthcare. Actually, 80% of our health is dictated by those social determinants of health. Where people were born, where they were raised, where they go to work, where they pray and play. And we know that many of those factor into both those traditional risk factors, but also those non-modifiable or non-traditional risk factors. One of them, which I was very, very privileged to have a paper that was outside the scope of the scientific statement that was co-authored with Dr. Michelle Albert, who was the first Black female president of the American Heart Association nationally. In this paper, we talk quite a bit about something called the superwoman schema, or another term is weathering. What this entails is that stereotyping, oppression, discrimination, either from sex or race, can absolutely impact the sympathetic nervous system, the inflammatory system, or the hypothalamic pituitary system. And all of that could increase allostatic load and lead to premature cognitive and cardiovascular health. As a result of this, this is where the focus should be when we're thinking about a changing paradigm in risk assessment. One thing that our scientific statement really wanted to highlight was that it's absolutely important to screen at all visits traditional risk factors, but it's also equally as important to talk about those non-traditional risk factors, those pregnancy-related risk factors, those other female-specific risk factors, and most importantly, the social determinants of health, the cultural issues and norms, and maybe language and health literacy, all of which truly impact cardiac disease in a much greater presence than just the traditional risk factors. Strategies to achieve this is really to promote culturally tailored interventions and education. Other strategies that we really wanted to hone in on also include the ability to make sure that these social determinants of health are emphasized through policies that ensure equitable healthcare access. We want to incorporate these non-traditional risk factors into our standard CVD assessment and increase Black women's representation in clinical research as well. When you think about cardiac research in general, we know that as a whole, women often are less studied and less represented in clinical trials. At best, it's about 30% for CAD or congestive heart failure. And then when you sort of hone in on race and ethnicity, it's even lower. We want to support community-based initiatives and peer-led programs. And I think that the American Heart Association is doing a phenomenal job in work across really the country and even nationally. And I think a large health enterprise like CommonSpirit may have the opportunity to partner in a more broader scale to achieve such strategies for the betterment of our nation. I know as it stands right now, there are implementations within CommonSpirit to ensure that all practices are screening for social determinants of health. And I think that as we become more comfortable in doing that with each and every visit, we're going to actually treat the patient as a whole and lead to better improved outcomes. So thank you for the opportunity to share this paper. I look forward to the conversations that we have in the future and any questions that we may have at the end of this topic. Thank you.
So my paper is entitled Contemplative Medicine, a Practical Application to Wellbeing 2.0. So the needs assessment for this came out of the 2022 Surgeon General's advisory when Dr. Murthy highlighted the urgent need to address healthcare worker burnout, which was crisis levels even before the pandemic. And for those of us that were frontline through the pandemic, we probably really identify with this, that, it was a difficult time with impacts on physician retention, for sure, economic impact, and physician well-being outcomes also have impacts on patient safety and satisfaction. As I've watched this evolution of physician wellness or well-being, I think it's best organized, and this is from the work of Tate Shanafelt with Stanford, in terms of this idea of 1.0 and 2.0, which is where we're going and where this paper addresses. And most of you in practice probably will feel this as well, that this idea of physician wellness was new, kind of beginning between 2005 and 2010, characterized by knowledge, awareness, initial studies. For those of us in med ed, we saw those ACGME changes, surveys, evaluations, and drawing these research links between physician burnout, productivity, turnover, well-being, quality of care, medical errors, or et cetera. So really building the case for why this is important, but without really practical solutions, both from cultural, personal, and systemic changes to support well-being. This is a small slide, but I wanted to include it because I really like this comparison of era of distress, well-being 1.0 and 2.0. And on the 2.0 side, what I think is really important to highlight is there are multiple systems-based changes that are highlighted. This is not a personal deficiency for the physicians. And there are many personal and community-based things that can impact well-being, including a sense of shared community, connection, agency. Agency is one of the strongest predictors of well-being, even amid a difficult workload. And this more simplified schematic shows this 2.0 idea with this quality of vulnerability, growth mindset, shared humanity, self-compassion, this idea of work-life integration rather than work-life balance, because balance is always, teetering one way or the other, and it takes effort to try to keep it in the middle. And that sense of community and meaning and purpose. But where I was left with reading this seminal paper was, well, how do we do that? And from the research on neuroplasticity and developing these patterns really within the brain towards the frontal lobe, away from the midbrain, towards a sense of agency, community connection. What is the mechanism by which that is developed? And so this idea of contemplative medicine, which really has arisen from hospice, palliative care, and chaplaincy, is I think a nice complement to this idea of well-being 2.0. And you can see the 2.0 ideas on the left and contemplative medicine, the sort of secret sauce or how-to on those particular qualities. It's consistent as well with the Stanford WellMD model, which has this three-pronged approach to physician well-being, which is culture, efficiency of practice, personal resilience. I think this will probably be updated at some point to reflect more systems-based language as well. So what is contemplative medicine? I alluded to it briefly before, but you can see it really is this buffet of contemplative type practices in the setting of deep community and connection with self, colleagues, patients. And it is designed to facilitate compassionate practice, generous listening, ability to process the difficult things of medicine that we really all deal with if we work at the bedside, and have the strong element of both agency and commensality and relationship. And so this intervention that I wrote about was regarding a 12-month cohort-based experiential learning as designed as a way to address the real and significant challenges of really sustainably practicing medicine. And those of us in clinical practice, I think, have felt this, in terms of post-pandemic changes with really the mass exodus of our colleagues towards non-clinical careers. And, staying in it is the work right now. So we had this 12-month cohort, mostly on Zoom, some in-person training, and through this had this strong mentorship, development of community, and tried to put forth this sense of agency, joy, and connection. We did a mixed methods quantitative assessment as well as some qualitative data. This had a small N of 34, wide range of specialties and years in practice. So this was a pilot study for this initial cohort. And the outcomes that we saw, we evaluated people on the Maslow burnout inventory because that really is the best, longest standing, well-known evaluation of burnout. And you can see on all three measures, emotional exhaustion, depersonalization, and personal accomplishment, all had statistically significant differences in a pre-post study in a paired t-test, with particular significance on personal accomplishment with a p-value of 0.0004. An interesting question to me as we considered the statistics for the paper was, well, we did this during the pandemic. Are these people, kind of significantly worse to begin with than a normative data set, or are we about the same? And so we also compared the participant baseline to a large normative data set. Granted, that was pre-pandemic. I think it was 2019 data on these similar measures. And you can see between our cohort and the normative data set, there was a significant difference in emotional exhaustion, which really makes sense for folks that were working through the pandemic, but that those same people decreased to pre-pandemic normative group levels in that same metric over the course of the intervention. I was actually more excited about these secondary outcomes because the Maslow burnout is the best and longest standing battery, but really when looking at the newer data coming out, looking at a sense of agency, community, connection, all of those are really the strongest predictors towards a sense of well-being. And this was pilot qualitative data, but very positive for these metrics among the study group. Limitations, obviously, this is a pilot study, a small sample size. There is limits to the widespread feasibility of this program. 12 months is much longer than most people will want to spend on this. And I think especially post-pandemic, we all have Zoom fatigue, and the idea of probably doing more training via Zoom is unpalatable to some. But the program has continued. And so we are now assessing the longer term outcomes for the subsequent cohort. So we now have a sample size of over 100, which is great. So looking at the qualitative assessment, revisiting the quantitative assessment. The next step, I think, is to see also if the outcomes are applicable with an abbreviated program. As a residency director, myself, I'm particularly interested if this is applicable within med ed for our residents as we think to develop as meaningful well-being programs as possible for those in graduate medical education. And local efforts to promote these contemplative practices. Marion Regional Medical Center is a leader on developing our peer support program, our commensality physician dinners, and really the background of those interventions is within the contemplative framework. This is not to say that all of this should be a personal or a cultural based approach, looking at that Stanford WellMD model. Systems-based change is still paramount when looking at the longevity of physician well-being and retention. Acknowledgements for the Zen Center, which the program was through, mentors for the program, and our statistician, and references. Thank you so much.
These were great talks. I think they fit together well and sort of have a thematic approach. And Dr. Sagar also tells me that she has some questions. Ankita, do you want to start? Oh, okay, I'll start. So I just, Dr. Kennard, it's interesting, your talk, and I remember the paper well. And the work that you're doing, I don't know if this is a question or a comment, but aligns with the CommonSpirit Health Physician Enterprise approach to well-being and professional fulfillment. And you talked about system changes and the importance of that. And that's part of what we are trying to do, particularly with how we ask people to be in clinic and all the things that bombard them throughout the day. And you mentioned empathy and sympathy, and there is a video, and I asked John if you can post in the chat. There's a wonderful video by Breen Brown where she talks about the difference. It's quite entertaining. We won't show it today, but I would encourage people to, there it is, to copy that down and watch that video. It's absolutely terrific. And the other comment I would make is that I think where we have landed in wellness and well-being is it's great to talk about it. It's great to talk about the statistics, but it's what do we do about it? And it definitely, at Marion Medical Center, you've sort of taken that proactive approach, as we have across the country, to try to get people into a better place. I don't know if you have any thoughts about that, but.
Yeah, thank you so much. And I agree with you. Brene Brown's TED Talk, Power of Vulnerability, I think it has something like 40 million views or something on
Yeah.
YouTube, and really changed the landscape of that kind of research. And yeah, I agree with you. I am really proud of what we're doing locally and to be part of CommonSpirit in terms of the what I see as real meaningful efforts towards well-being and connection and efficiency of practice and the things that will provide career longevity and satisfaction. Thank you.
Right. Yeah. And just one other comment for Marion. I know Dr. Oates is on, but you have sort of bled this work over into your trainees, which I don't think we do great on across the country, but I think that's the best practice.
Thank you. Yes, bringing it into the residency is a real joy.
I have a couple more, but if you want to do some questions, and
Sure.
then we can come back, so I don't hog
Yeah.
all the questions.
No,
Thank
that's
you.
okay. And I think it's really a question for all three of you. So one of the things that's striking to me when we chose these three topics, we thought, okay, this is three very good variety of topics, right? There's a theme that I am noticing across the board, right? Which is the idea that how do you value the human spirit, whether it is in the patient experience, whether it is addressing inequities, or whether it's addressing our own workforce. So I wanted to ask each of you to comment on how did you come up with this idea? And is this something that you said, I am going to one day write this paper? Or, and I know Dr. Lee, you sort of alluded to it, but where did this come from? And how did you two find the commitment and the dedication and the time to do this work? Because we know you have 7 other jobs that you do. So I guess I will start with Dr. Lee, then Dr. Bond, and then Dr. Kennard.
Great question. So yes, mine was an embarrassing online review that was terrible, and I took that, to heart, and I turned it around. And I feel like, that is an opportunity. Any challenge, anything, it's an opportunity to improve things. And so I took that to heart. And then I felt like, we dedicated the improvement process and learned all about this really interesting and patient experience data. And I wanted it to be shared. And I felt like if we write it up and put it in the medical literature, it can be shared and those learnings can live on. And I was actually just thinking about this as I was listening to these presentations. And I mean, this is something we can put into practice this moment, right? Every patient room you walk into as a provider, you can actually just think about and acknowledge what's going on with the patient, right? How are you feeling today? Is there anything I can do to make you more comfortable? And that acknowledges that you care about their experience that day. And this one was about a procedure. And so I'm thinking about procedures, and we walk in so focused on what we have to do, right? For me, it's like, I need to do this screening for bladder cancer. I need to do this, diagnostic cystoscopy. But it's now that I've shifted my mindset to greeting the patient, listening to the patient, and just thinking about what they're experiencing. We also implemented privacy screens, right, to make them feel less vulnerable. So all the little things matter, and they can feel it.
Yeah. If I could just add in there, I recall that your paper ended with something to the effect of outcomes are much better when the patients participate in the process, so to speak. And so it's great for those patients, but I'm wondering if now, a year or two later, if when someone comes in for a cystoscopy, you share with them that, we did a special design on this and got, your predecessor's input, and so I hope it's, because I think that piece gets lost. It just becomes part of the routine.
Right. I love that. I love we really need to integrate patients into every process, right? Their input matters so much. And so there's actually the patient who was a member of this improvement project is an author on the paper. And so she was a real partner in this. And so it's just a testament to how we really need to incorporate patients into everything.
Nice.
Yeah, I'll just echo a lot of what Dr. Lee said. I think that the personal experience truly does add a powerful and authentic layer to all of our research, all of what we do day to day in our medical care. For me, it was hearing many of these patients that see me just because of my area of expertise and understanding that sometimes they're not always heard, and oftentimes they're dismissed. So having research that actually focuses in on why perhaps they're having such high rates, particularly at such young ages, really takes that burden off of them to sort of advocate for themselves, but really opens the minds that we should be doing this across the board. Yes, that being said, it still also justifies the fact that when it comes to particularly cardiovascular disease, thinking about the patient at the center, like from a holistic approach, is probably going to be the better approach to just leading to better outcomes. This paper was really sort of like a brainchild also for all of us in a working group that work with each other nationally with the American Heart Association. And as I mentioned, majority are women, and all of us come from diverse groups and race and ethnic groups. So we really wanted to hone in and say, well, we need a scientific statement that's targeting women, but also women of color. That way we can, to the masses, educate what those differences look like and really what our healthcare system should be emphasizing to improve those patient outcomes. And I think as a result of it, it's led to many work that actually is focusing in on these aspects. I think really every clinical study should look at really those non-traditional factors that impact each and every medical condition, not just cardiovascular disease. Because what we probably will see is that many of those social aspects, those social determinants of health, impact all medical conditions. We know this. And as a result of that, I think it really opens up that mindset and the eyes to say, okay, well, maybe we should be thinking about health from a different perspective. Let's get the personalization of health. Let's incorporate those lived experiences of our patients and actually see how is that impacting their overall outcomes. And I think the moment we do that, again, we're going to just lead to better outcomes. Data supports that. So for me, that is why this was such a passionate project for me to be involved in, for my patients' lived experiences, and honestly, even my own lived experiences being a Black female in the United States. So I was very fortunate to have the opportunity to be part of this awesome paper.
And while we have you, could you say 30 or 60 seconds, talk about allostatic load?
Yeah, absolutely. So the premise of that is that as these lived experiences or these episodic high stress situations that are as a result of periods of discrimination, be it against sex, gender discrimination, race, ethnic discrimination, conscious biases, unconscious biases, as you're going through your day-to-day experience, that is going to overstimulate all of those systems I mentioned, right? The sympathetic nervous system. Also, your hypothalamic pituitary is going to release those cortisol stress hormones. And all of that is increasing and targeting all organs, including your brain and your heart. So as a result of that, this is why we believe specifically the greatest risk population, which as it stands from a cardiovascular perspective, are Black women, there tends to be a higher rate of morbidity and mortality, especially at younger ages, because of those lived experiences that are occurring. So we really have to be mindful of the importance of asking people, how are they doing, screening for anxiety, depression, and also understanding that what they may be going through day to day could actually be impacting their overall outcomes as well as their cardiovascular health. So that's what that allostatic load is, because it's that increased load in all of those areas, all of those systems, unfortunately, that are rewiring their body to be more predisposed to the earlier onset of those conditions.
Fair enough. Thank you. Dr. Sagar.
Yeah. I wanted to pull Dr. Kennard in, so I'll give you two options, Dr. Kennard, because we got more questions coming up. Our audience getting super excited. So either you can answer the question I asked, which was, what is your personal connection to the topic that you're doing research, and did you always want to do research in this, or was there something that triggered? Or I can give you one of the audience member questions, which similar, have you thought about, and this is from Dr. Jackson, about the science of kindness, compassion, and empathy, and how that can be applied to the work that we do?
Thank you. You know, I just hearing these, I'm so struck on how beautifully all three of these papers dovetail
Yes.
together, even though they are, you know, different topics and different categories, because, you know, listening to Dr. Lee's paper about the patient experience, and I just love, you know, the radical honesty of where this came from and, you know, bringing this into practice. And then Dr. Bond's work on everything that you do, but really, you know, I resonate particularly with that idea of allostatic load because we see that too with the well-being literature for women in the pandemic, you know, that, you know, women worked full time, then they carried the load. And these are physician women, right? That carried the load of homeschooling, carried the load at home. And, you know, it's just like you said, you know, that kind of um, rewiring within the body's homeostatic systems and where do we go from there. And that's why I felt like writing my paper was important because it started to open that conversation about practical ways, you know, that someone could, you know, look at that in a system that is, you know, very difficult. And then looking at the science of kindness, compassion, empathy, all of that, you know, goes in. Like, this is the science. Like, these p-values are great. Like, we're adding to the literature on this, and not from, you know, just a personal level, but looking at teams and systems and partnerships with the organization. You know, this really gives the data and the science to support the work that we're doing. And, you know, I'm particularly excited about the peer support and the commensality programs within CommonSpirit.
That's a great advertisement. I
Thank
hope
you.
everybody's listening to that.
We did not plant her, we promise. I think we also have a question from the audience around, as you're doing this work and you're continuing your research, has your perspective either personally on the practice of medicine or just overall system changed because of the work that you're doing, if at all? So I'll go to, I know, Dr. Lee, you're in transit, so we'll come back to you. Hopefully you're in a safe spot then. Let's do Dr. Bond, Dr. Kennard, and then Dr. Lee.
Yeah, so yeah, my practice definitely has changed immensely. I'm also very fortunate because I get to work with the residents and the fellows. So I'm making it a very specific point to ensure that their practices also are not changing, but this is how they think it's normal, right? Day to day, that this is what they should be doing. And this is really what we should be focusing on. Again, from a cardiovascular perspective, the more we understand what's really leading to the conditions, the better it will be, because then we can really help to better target our therapy, manage patients. I think the future of cardiac disease is more precision medicine, which is targeting, right, sort of what the actual underlying culprit is, and then trying to help our patients understand strategies to best deal with that. So for me, this is something that we often do whenever I have a new patient, and then periodically when I'm seeing patients just for follow-up. We're always trying to assess those social aspects, those social determinants of health, asking questions as it pertains to their overall mental health and wellness, because all of that does, unfortunately, tie into their not only traditional risk factors, but how well we're going to be successful in treating their cardiac conditions too. So I'm excited that I get to sort of teach the future generation as well, to make sure that they're putting these tools and implementing these tools. That way we're hopefully going to see good outcomes moving forward in the next 10 years. That's what my goal is. In the next 10 years, we're seeing that instead of rates in these young aged population increasing, it's actually steadily coming down because now we're targeting and focusing on the things we should be.
I think I'm most excited about this in graduate medical education. Uh, I'm passionate and in leadership for physician well-being overall for OBGYNs, but I see the biggest impact with my residents and taking such good care. We were fortunate to implement some of these ideas in our residency program and then present them at CREOG, which is the academic conference for OBGYN education. And really as a model for a more comprehensive, meaningful way to deliver well-being education within residency. And I think about my own residency where, none of this was really talked about at all. And yet, we all have difficult outcomes. We all have unanticipated things that happen, patients, difficult patients. And so having that open and honest conversation, and vulnerability, not in terms of over disclosure, but in terms of developing a real sense of connection with colleagues and with others for longitudinal support, and then introducing these contemplative practices, I think is incredibly meaningful work. And so I am just glad to be part of it.
Great work, both of you. I really impressed. I think that we should continue to aim high in healthcare. We can create extraordinary patient experiences by enacting the principles and the values of CommonSpirit. And I think it can have big impact on patient satisfaction. And it starts with the people. It starts with understanding the patient perspective and really taking it to heart. And so, yeah, I'm just excited for the next opportunity, the next improvement project. Yeah.
Great. On behalf of all of our team and Dr. Sagar and myself and John and Rachel, thank you both for helping us put this together. We really appreciate, and I think it is true that there was some method in picking these papers and clumping them together, but I don't think we realized the full impact of how well they fit together and how well the three of you fit together. So we are very appreciative. And I just want to go back to one thing Dr. Kennard said. She talked about work-life balance, and then she talked about work-life integration. And I think there is something to that. And because of it, I believe that the care we provide and what we do for patients brings great sustenance and energy and sort of life source to all of us. And so when we talk about balancing it, it's sort of like the good with the bad. But when we talk about integrating those positive things, I think that's an important concept. But to the three of you, this has been a great discussion, far exceeding our, not that we had bad expectations, but I do think it really came together so nicely. So thank you, all of you. And thanks to our audience and for folks who joined us this morning. We will, of course, publish the links so the other folks can listen. And we really appreciate everyone's time this morning and hope you have a safe holiday season with friends, family, and all concerned. So thank you very much.